agendas at the door and come together to think about a key question, which is a different question that's often asked in the big policy discussions. And that question isn't what does success look like? What's the right vision for the long term? But just a very, if you will, practical question of what could we cooperate on over the next 12 to 18 months to bend the curve towards success. So if we think about, say, 2021 or 2022 coming soon, beyond the existing plans we have, budgets we have this year in our respective organizations, if we think to next year and what's upcoming, what could be done if we were to cooperate to pick some things that would move the ball forward? And if you forgive the sports metaphor, whether you like football or soccer or anything in between, it's not tell us how to score a goal or tell us how to get the touchdown, but what's a first down or a next pass? Just what's a way to move the ball forward? Because there's so many ways to move the ball forward, and they might be creative, they might be lateral. There's just a lot of ways to do it. And so we've been finding that in a few experimentations that we've done at the global level, but also at university level and at community level, that people find that this seems to be an interesting formula of trying to, if you will, ease the pressure on solving everything to try to find something that people could cooperate on that would be additive and a next step. The other big piece of this is that so much of the sustainable development agenda, and I would also say our awareness around COVID, is that everything's connected to everything. So we've seen one microscopic imbalance in one community in the world has permeated to upend hundreds of millions of jobs, billions of lives, and the death counts are going up in many parts of the world, horrifyingly, while the job counts are going down. And it's a hugely uncertain environment, and this is all interconnected. And in respecting that and even honoring that, if I were to speak bluntly, very often a lot of the cross-cutting, interconnected, intersectional discussions are ultimately about how someone working on another SDG needs to help me solve mine. And one of the things we found is that that often doesn't work so well. But what can work well is if each community has a place to problem solve on their own and see what they see as an opportunity, and then bring all the communities together to listen to what each other sees as an opportunity. And that then gives much more of a water cooler opportunity, if you will, for people to bubble up opportunities to cooperate across the goals. We've done this at what we call the flagship global policy level. Over the past couple of years, we're about to put out a report next week with what all the rooms came up with and picking some issue within each goal that people thought could move forward. And then some big picture synthesis ideas. But we're very excited to work with Kristen and the whole Global Washington team, because this is what we hope can be through different permutations, an approach that different communities can take on. And so we want to work with others to see how could this be useful to you. So I just add my colleague Jacob Taylor is on the line. He's a PhD social anthropologist working on how communities click. And so how to have high performance group work. So we're really analytically interested in how to develop toolkits and things to help make this a broader method. So let me stop there. Let me thank you, Kristen. We're delighted to do this in backup dancer to your headline efforts, and just happy to be here. So thank you.
Thanks so much, John. As I mentioned, John and Jacob have been great advisors as we roll out this initiative across the United States and into the future. So thanks again. So next I'm going to introduce George Durham, who's our facilitator for today. George is the executive director of Linksbridge, which is a nonprofit consulting firm and he's done a lot of work with the Gates Foundation and others in the global health space. And he's just a fantastic facilitator. So I'm very fortunate to have George with us today. So George, you want to go through our agenda?
Thanks, Kristen. Really great to be here with all of you. Thank you, everyone, for taking 2 hours out of your day. I know for some of you, it's very late in the day or even middle of the night. I'm really looking forward to the discussion. As Kristen mentions, my name is George Durham. I'll be really hoping to try to facilitate and guide the discussion today. As Kristen and John both shared earlier, we really do hope this will be a discussion. I've prepared just a few slides to kind of guide us, but we're not going to be paying attention to slides, really. We're really going to be paying attention to one another. As Kristen mentions, I run a small Seattle-based global health advisory and research firm called Linksbridge. We've gotten actually to work with some of you on the line, but also a number of organizations in the global health space and the global development space. And I see some familiar faces and others that I don't know. So I really appreciate the chance to be with you all. Let me just go through the agenda really, really quickly. I'm going to kind of go through some rules of engagement a little bit and kind of talk about how we hope to run today. And then we'll just do a little bit of context setting or additional context setting. And then we're hoping to spend really the first half hour or so, 25 minutes, really talking about kind of the problem and the context in which this is all taking place that we want to think about and discuss today. We will then later in the afternoon break into 2 different breakout groups to then think much more tactically about potential solutions and ways to address the problems that we're facing. As Kristen outlined, as John mentioned, we really are, for this particular discussion, and there are similar discussions that have happened and are happening around the country, we really are focused primarily on health systems and how to improve and make changes to strengthening health systems around the world, and then also equitable access to vaccines. So that's really where we want to kind of be focused today. In terms of our discussion, you hopefully all saw Kristen's note. We're going to kind of invoke the Chatham House rule, which really is about being able to have a free-flowing, very candid discussion that will be kept in confidence. So everyone is allowed to certainly take from this discussion insights, information, helpful things that they learn or that they hear, but not, those things aren't to be attributed. So you shouldn't say, oh, well, so-and-so at this organization said this, or this individual at this organization said that. Rather, it's an opportunity for us really to be open, to be honest, to have dialogue with one another. The intent, the spirit of the Chatham House rule really is to share what you receive, but not to reveal the source or the sources, so that free-flowing information can take place. I also hope that we will really think about how we can make space for others and also take space where appropriate. If you are maybe someone who feels very comfortable speaking in this kind of forum, perhaps think about how you can sit back a little and let others find opportunities to speak. On the other hand, if you're someone who tends to perhaps be a little quieter, I hope that you will really deliberately think about how you can take some space and some time to let others hear your voice. To that end, there are a few different things that I'm hoping we'll do to facilitate that. So in Zoom, and I'm presuming that most of you have some basic familiarity with it, since it's a tool that I know so many have now been using for so long. But please do, if you haven't already, you can open up the chat functionality. We will be watching the chat throughout the discussion. So if you have comments you would like to make, but don't necessarily want to interject verbally at the time, put it in the chat. That's a really great way to do that. And we have kind of that record for the note takers and things. Similarly, if you click on the participants icon of your Zoom software, you should see at the bottom of that screen a little option to raise hand. So if you have comments, if you want to make an interjection, please do raise your hand. That's really helpful to me as the facilitator and to others just to signal that you'd like to make a comment. As Kristen mentioned, I really, really highly encourage video, especially and specifically when you are speaking. It's just a great way for others to see you and to engage and to create some of that community, as Kristen mentioned. I also understand there are bandwidth constraints and there are perhaps coworker or other household members constraints. And so if you can't use video, that's okay as well. And then I would encourage, the first time you take the floor, it would be helpful if you'll just briefly introduce yourself, just your name, your affiliation. That can be really helpful for everyone. So with that said, let me kind of just do a little more context setting. And Kristen did a great job of this, of course, but I think as I thought about coming into today's discussion and the current context in which we find ourselves, the COVID-19 pandemic really has, to my mind, illustrated, illuminated, shined a spotlight onto some of the challenges that we face around health systems, around potential challenges and weaknesses in those health systems, and also around just some of the equity issues around vaccine, around medicines, and getting those tools and those resources to others who need them. SDG 3, as I'm sure many of you are familiar, notes that the need to support research, development, and universal access to affordable vaccines and medicines. That's something we want to be thinking about today in that context. And I'm hopeful that in this next few minutes of discussion, we can really think about that problem landscape. So how are we solving for some of the issues that COVID-19 has brought into such sharp relief? How are we beginning to think about and solve for some of the challenges of equitable distribution of vaccines, certainly of COVID vaccines, but even more broadly, immunizations in general? To kind of get us started, and I think important as subtext, especially as we go into the breakout groups, it will be helpful for you to be thinking about what's the role of your organization in this. If you're a US-based organization or company, what can you be doing? What are you doing in terms of thinking about some of that capacity building in those low and middle income countries? And because this is a global Washington and a Seattle discussion, I think it will be instructive and important to remember, to be thinking about what we as a larger global Seattle and global Washington community can be doing and what unique roles or opportunities we may have. So to get started, what I'd like to do is actually pose questions to just a few of you, and then we will open it up broadly for discussion. And again, we'll keep an eye on chat, and please do raise your hand as you have comments. But I'd like to first put a question to Ami, if I may, and just to get a sense of what you have observed and learned as you've seen some of the weaknesses and challenges that have shined through as a result of the COVID-19 pandemic in health systems. Are there certain factors in your mind that you've seen have either really helped to prepare countries or put countries in a better circumstance to respond? What have you seen? What have you learned as a result of COVID where some countries have done better than others? And you're muted, Ami, so you'll want to come off mute.
Okay, I've been muted by the organizer. Hi everyone, and thank you for having PAS in this interesting roundtable. I'm Amina Toussar from PAS. I'm overseeing our country program in Senegal and also our regional hub in West Africa. To respond to your question, I think that what we've learned is that the preconceived notion that wealthier countries have stronger and more resilient health system is fundamentally flawed. We are all subject to some very real vulnerabilities: climate change, the way public health is funded, accountability, transparency or lack of transparency in public health response. Overcoming these things will take solidarity both within our countries and across countries. I think Senegal has been fortunate. We've not experienced COVID in the same way many other places have. We have less than 0.1% of prevalence of COVID and less than 400 total deaths. So if we compare that with the US, you can see that the outbreak has hit US more severely and disproportionately. But in Senegal, we take public health very seriously, and we were able to prepare because we are very much aware that our health system can't afford to have an outbreak hitting our country like it has hit in the European countries or the American countries. We know, and our people know how to respond to an outbreak. This is what we did with Ebola in 2014. And we have systems set up now that have allowed us to be proactive from the moment the first case were announced. It doesn't mean that it hasn't been hard. I think that we've seen how our system lacks resources, lack equipment, and the most needed equipment to respond to the outbreak. I think we still have room to improve for everyone to live longer, to have healthy lives in Senegal. So we are responding to COVID on top of many other public health challenges, and I think that is much more important is the malaria control, making sure that routine immunization continues, all the essential health services that have not been able to function in the same way at the same time or at the same capacity because of social distancing and quarantine. It has been a very challenging time for us and for the health system. So even for a country like Senegal that has made upfront investment in epidemic response, there is still an issue of resourcing. We can't take existing funds and redirect them to pandemic response without downstream public health implication. We talk about the cycle of panic and neglect, this idea that we prioritize epidemic response, but often when it is too late and not sustainably. And you see this in wealthy countries and in less wealthy countries. So bottom line is, if we invest now in public health system and infrastructure, we'll be prepared for everything.
Right. Thank you, Ami. Interesting to get to hear some of how, Senegal's investments, or in certain things, have lent to some of that more successful outcome in some ways, but certainly where there are real challenges as well. Emily, if I can go to you, I'd love to hear some perspective from you, from Village Reach. One of the things we want to make sure we talk about today and are thinking about is just equitable access of healthcare, broadly speaking. And I'd be curious what you have observed in your work around supply chains and logistics that reveal that you are worried about, or that are revealing some of the frailties that we're all going to face as we think about actually distributing a vaccine en masse to people who need it.
Sure. Great. Thank you so much, and great to be here with all of you. So I think a couple points I want to make. One is that the health supply chains in a lot of the countries that we work in Africa, they're built around certain assumptions, right? And those are assumptions having to do with where is care actually provided? What is that location? What type of care is provided there? What are the actual handling characteristics of the medicines and products? What's the size of them? What are the distribution routes that work in a normal sort of day-to-day way? And what we've seen during COVID is that a couple of those assumptions, or a couple of the things that supply chains have been planned around, have shifted greatly. And I'll give two examples of that, and then talk a little bit about what then that means maybe for vaccine distribution. So the first shift that we've seen, which I know many of you have seen in your work too, is COVID has pushed care out of facilities. And actually, I thought that the article, Kristen, that you sent ahead of time, talking about this and talking about health systems in a really clear and concise way. One of the things that's happened with COVID is people have become afraid to go into facilities. We see that here in the US, we see that in sub-Saharan Africa. This is not a unique situation. But what that means is that there's been a very significant impact, as Ami said, on routine care. And what that means for supply chains is that we do have to think about where routine care can be more successfully pushed outside of the facility, and how supply chains respond to that. And so governments have been having to address that in real time. Some countries are very well equipped to address that. They already have community health systems set up. They already understand how to distribute medicines to that level, but other health systems have not been as prepared for that shift. The second really big shift that we've seen that I think does point to a challenge that we'll see in vaccine distribution too is when something like COVID creates a massive change in the type of product that's flowing through the supply chain. And the best example of this that we've seen in COVID is protective equipment. So PPE, personal protective equipment for healthcare workers. The volume of protective equipment that is flowing through supply chains right now is enormous. Just as an example, we've been involved in one of the largest efforts to get protective equipment to the community health workforce across a number of countries in sub-Saharan Africa. And just for the community health workforce, the volumes are extreme. In DRC, it took 3 days for 9 World Food Program trucks to move just masks and face shields for only 5 of DRC's 26 provinces from the airport to the warehouse where they were going to be stored. And that's before they actually get distributed out to the provinces and to the community level. And so those volumes, a lot of the supply chains that we work with, they weren't built, the medical supply chains were not built to manage that sort of volume. And so a lot of countries didn't have great plan, they certainly have some PPE in their supply chain. They certainly maybe have had some outbreaks where they have had to, have PPE flow in, but not at this volume, not for this amount of time, not sort of to cover their whole health workforce. And so we saw a lot of countries scrambling to have the warehousing locations, the trucking capacity, just all of those logistics to be able to move those volumes, because it's not what they were built for and they've had to adapt. And so when we look ahead at the vaccine, these are some of the factors that we need to look at. So we know from previous vaccine introductions that countries that are the most prepared are going to likely be the first to get vaccines. And at the same time, we have the health departments and the ministries of health in the countries where we work certainly already dealing with managing essential services during a time of sort of travel and movement disruption. We've seen measles outbreaks, we've seen polio outbreaks in the countries where we work. And so we're already trying to sort of deal with the immediate and urgent needs, and then also asking countries to start planning for what is really a completely unknown product at this point in time. So we don't know the handling requirements, we don't know the size of the vials, we don't know the amount that each country will get, we don't know when they'll get it. We also know that most vaccination programs, and this is not new to most of you, target kids and pregnant women. That's not the target for the COVID vaccine. It will most likely initially be health workers and vulnerable populations, maybe because of being immunocompromised or because of age. And so this is sort of a different model for the vaccine supply chain to be thinking about. And we do have other instances and other examples of where we do have to think about, ages other than children and pregnant women, but certainly that is the primary mechanism through which vaccine programs are sort of the primary structures that vaccine programs are built around right now. The other piece, which there's a lot of news about in the US right now, and is certainly a concern in the country where we work, is the ultra cold chain requirements. So although there is a chance that a vaccine candidate will not need ultra cold chain, the most promising candidates do. And the best example that we have of that right now is the Ebola vaccine. But again, the Ebola vaccine is given in very concentrated geographic areas and in relatively small numbers compared to what we're talking about with the COVID vaccine. So this infrastructure alone requires significant partnerships, cost, and effort for countries. And so when you're thinking about, if you're sitting at the country level trying to figure out how to plan for this, and certainly this is happening here in the US too, you need to know how much resource to put into this planning and at what and when and at what cost. And so right now, some of our projections show that at the worst case, low and middle income countries may receive only 5% of what they need. We certainly hope for a much better case, but even then we're talking 20%, 30% of what they need initially. And so even that difference between 5 and 20%, I think points to what sort of planning and preparation you do. So in terms of what we do about this, I think some of the interventions actually are really basic and go back to some of the principles around this roundtable discussion, which is we need to not forget how vaccines actually get delivered. And there are all of these logistics constraints that I've just talked about that need to be planned around. But there's also the reality that we cannot lose focus on the healthcare workers who will actually be delivering those vaccines. And if we lose focus on that, then we run the risk of not being successful in any of our efforts. One of a good colleague and friend who many of you know, Raj Punjabi from Last Mile Health, recently said vaccines don't deliver themselves, healthcare workers do. And so as we think about recommendations, there's a lot of effort and emphasis right now going into guidelines, going into planning, going into modeling, and that's very important, but let's not lose sight of the fact that it's the healthcare workers themselves who are actually going to deliver this vaccine. And if we don't think about how they're protected, how they're informed, how they're communicated with, and also as the recipients of the vaccine, most likely, the first recipients of the vaccine, how much trust do they have and how are we working very closely with them? And then I think that the second thing is, how do we reduce some of the noise? How do we think about how to get really targeted, focused guidance out to countries that can help them plan and be ready, but also reduce some of the churn and the noise that's going on in the global community right now. So I look forward to more conversation about this. I think there are a lot of other things that we can be doing as a community.
Right. Thanks, Emily. And I appreciate the reminder that it is, it's ultimately, it's those healthcare workers who have to get it out there and distribute. And I think your allusion to Ebola and other health crises is actually a nice segue. I'd like to put one more question to Margaret Schuler from World Vision, and then I encourage you all to be thinking about, thoughts you have, comments you'd like to make on kind of the broader context and the problem we are facing and up against, and where there might be opportunities that we can discuss in our breakout groups. But Margaret, I know World Vision works in some of the most remote areas of the world, has extensive reach. What have you all learned, throughout and as a result of the COVID pandemic, where there were successes from Ebola or from other health emergencies that informed perhaps more successful responses to COVID, and where might COVID be informing future successful responses to other things?
Yeah, great. Thanks so much, everybody. It's great to be with all of you today. I'll focus a little bit on the community mobilization aspect of all of this. And when I think about, our work in the past with different health crises such as HIV and AIDS and Ebola, we've learned that trusted and influential members in a community are a critical component to reduce barriers to good health and behavior change within that community. And I'll use the example of our West Africa Ebola epidemic, where World Vision reached over 1.6 million people, including 550,000 children, primarily in Sierra Leone. And in 2016, we partnered with Johns Hopkins University to conduct a formative research study to look back and understand why there were no Ebola deaths among all 59,000 World Vision supported children in the Bo district of Sierra Leone when the Ebola outbreak began in 2014. And what we learned was that a critical factor in preventing deaths was due to partnering with government and the integrated and multi-sectoral Ebola response we tailored in partnership with communities. Our prior emergency response efforts had shown us that faith leaders are among the most influential members in a community, and that they wield considerable influence over culture and what actions are prescribed or prohibited in their communities. And so we created what we call a Channels of Hope model. It's an approach we use to equip faith leaders to overcome their silence and judgment of HIV and AIDS when the pandemic took hold in the 80s and 90s, and to help others do the same. And so this has been a strength that we've adapted in various contexts to help in mobilization in other emergency response efforts, including Ebola. So currently with our World Vision global response to COVID-19, we are working in over 70 countries and using some of the similar approaches, and it's a multi-pronged approach building on the experiences, as others have talked about, with public health responses to Ebola and HIV and AIDS. And we focus on scaling up preventive measures to limit the spread of the disease, strengthening health systems and health workers, and supporting children impacted through COVID through a multi-sector approach. But as we prepare for an available vaccine, World Vision's developing a tailored Channels of Hope COVID-19 vaccine module for community mobilization to help ensure that the vaccine reaches the last mile and the most vulnerable and displaced populations. And so then in the future, we intend to harness those community health workers. For World Vision, it's over 150,000 that we've trained on preventive messages with COVID to contain the spread and to focus on social and behavior change mobilization efforts to erase stigma. And our role as a community-based and community development organization is to, in vaccine delivery, will be to position World Vision offices to assist Ministry of Health staff to train community health workers and to help communities trust the system. I say trust is key here, and to know where to access vaccinations. Using and adapting our current community mobilization strategies from different contexts. So I would say that in summary, we've really built an approach over a number of years in response to other public health crises, and have utilized that and scaled that up in the COVID response, and will do so as well for the vaccine response as well.
Thank you, Margaret. I'd love to open the floor now to other comments. Are we thinking about this in the right way? Where are there, are there additional problems as it relates to health system strengthening and, equitable vaccine delivery that we need to be considering or thinking about? I'd love to see any comments, any hands. We'll look for those. Martin, I see a hand. Let's go to you.
Thanks, George, and great to be with everyone. My name is Martin Edlund, CEO of Malaria No More. Aminatu, we haven't met, but I lived and worked in Senegal for a time, and I'm eager to come back. so let me know when it's safe to do so. Maybe just to add a related issue that we've been thinking a lot about. So Malaria No More is mostly focused on health financing, and obviously malaria is in focus for us. As we look at health financing in the context of COVID and the SDGs, I think we're at a make or break moment. When you look back and think about the Millennium Development Goals, which everyone knows ran from 2000 to 2015, it was right around 2005, 2006 that the real money came to the table. Right, that's when the Global Fund was launched. That's when PEPFAR was launched, PMI, the President's Malaria Initiative, and other initiatives were launched. And we're nowhere close to the resources that the WHO estimates we need for SDG 3. And when you think about the advent of COVID, there's an argument to be made that the Sustainable Development Goals just became the unsustainable development goals, and that we can't reach our goal. If you think about, the cost to countries, lower middle income countries, is an additional 100 to 200 billion. The debt service payments of 100 billion in the next couple of years for countries in sub-Saharan Africa, and the fact that donor countries have already spent over $10 trillion in their domestic response. And so money is kind of constrained everywhere you look around the table. But I think it's a little more hopeful than I'm suggesting. I do think there's a change in mindset. I do think global health and infectious disease are front and center in people's minds in a way that they haven't been ever in our lifetimes, and may not be again. And so the question that we're grappling with is how do we resource these efforts, not just the direct COVID efforts around therapeutics and vaccines and their delivery, but how do we maintain the progress toward the broader goals that many of us are thinking about? I won't go into detail, but just as fodder, we're thinking about a few things. We're thinking about private capital. How do you bring kind of return-seeking capital to the table and kind of align that and get co-investment alongside donors and domestic spending in a way that hasn't happened at scale before in a place like sub-Saharan Africa? How do you think about the private sector as a means of delivering routine care and impact. One of the things that we've been working on and hope to finalize it next week is what we call a guarantee facility. We're working with the U.S. Development Finance Corporation, Rockefeller Skoll, and a few others. And what we're able to do is backstop loans, about $30 million in loans to 1,600 clinics across 5 countries in Africa, really just to keep the doors open, to allow them to purchase PPE and provide care. We're bundling that with TA and training, working through a group called the Medical Credit Fund. But it's something we haven't done before. And I know in the malaria fight anyway, we've often ignored private sector as a means of delivery. And then the last thing that we're thinking a lot about, and we're at early stages, is how can we challenge ourselves in this moment to kind of get out of our boxes, get out of our kind of parochial, I'm an advocate for malaria, you're an advocate for some other set of issues, and think about the capacities that need investment to accomplish all of our goals. And, you know, to take the example of malaria, a bit of a one-trick pony here. You know, we look at capacity needs like community health workers, like frontline testing and treatment, like surveillance and data systems, as fundamental to achieving our mission of eradicating malaria from the planet. You know, for everyone who's watching COVID response and broader pandemic preparedness, those are the same capacities you need to find and fight pandemics. And so I think if we can be creative enough and kind of work across our boundaries, there are ways to direct new funding in ways that can advance multiple goals. And I do think with a Biden-Harris election and I think a strong urge by the US to use global health as a means of partnership and diplomacy in the world, I think there will be expanded resources as we head into next year. I'll stop there.
Great. Thanks, Martin. I think the point on sort of the financial resources being part of that larger challenge or problem we're facing is really, really important. We've got about 5 or 6 minutes. I want to keep us close to on time. And again, I appreciated Martin's comments. You know, let's be thinking about what some of the other aspects are to the problem we're trying to solve. We'll of course spend the next 45-minute section talking about potential solutions. I see hands from Trina and then Ezra. So let's go to Trina and then Ezra.
Thank you. I'm Trina Helderman. I'm a health advisor with Medical Teams International, and I have a few thoughts. So I'll maybe save some of them for the breakout sessions. But I think one of the things that in the conversations I've been having around the implementation of the vaccine, I mean, Emily, you mentioned we don't actually know how many vaccines each of the countries are going to get, and so even though there's these theoretical SAGE recommendations of like 3% of the population for healthcare workers and 20% for the vulnerable, I think that, yeah, I have a lot of concerns that probably that won't necessarily happen. But then there's also this challenge of if you step way back and try to look at global prevalence and caseloads and what's happening, you may actually say, well, it's not the low middle income or the low resource settings that actually probably need the vaccine more because we're not seeing as many cases there. And I think that's one of the biggest challenges, is that not only in these settings do they have the usual challenges with, you know, accessing healthcare, but they also have challenges with having lack of testing of capabilities, resources for testing, but then also just data management and trying to be able to have good data coming out of some of these countries. So there are some efforts in different places. If we look at Bangladesh, like where the Rohingya population is, if we look at Uganda, you know, there's much lower prevalence or incidence of cases than what we would anticipate. And it's very difficult to know, is that just because, you know, we're not able to test sufficiently, that we're not getting enough tests out there, or are the cases actually that much lower? And if they are really that much lower, there could be an argument to say, well, we might not need to think so much about the vaccine in those areas, but think more on prevention, as it's been mentioned, but then also how do we ensure people feel safe so that they continue to access healthcare services, because I think that's one of the big things we've seen is people are afraid of COVID, whether they're afraid they're going to get COVID or afraid they'll get tested for COVID and then get put into an isolation center, that they then are not coming to the health facilities. So vaccination coverage rates are going down. We have more home deliveries, which we all know will eventually increase maternal mortality. And so I think that I'm struggling a little bit to try to think through. Obviously, we want to have equity. It's also looking at, it's probably likely a lot more people in Uganda right now are dying from malaria than they are from COVID, even if we did have better testing. So are we getting distracted a little bit, as we did with Ebola in 2014, or even with the outbreak in DRC, that if we have all of our eggs in the outbreak basket, then we end up forgetting some of the really essential things within that are causing a lot of deaths, like the malaria, the pneumonias, the diarrheas in children under 5, and maternal deaths. So yeah, I think it's a bit of a challenge to know, yeah, the right way to go, but perhaps it's pursuing a bit of both sides to try to ensure that we can make the biggest difference. Thanks.
Thanks, Trina. Ezra? You're muted, Ezra, so you need to come off mute.
Yes, good afternoon. Thank you. Thank you, Kristen, for really organizing such a fantastic event. My name is Ezra Tishomi. I'm with Rotary International. I'm the Polio Plus chair. As you all know, Rotary has been involved in the eradication of polio. And just recently, we celebrated the eradication of polio from Nigeria, which was an endemic country. As Rotarians, we worked with most of you, World Vision and others, to really partner in everywhere where we deemed is necessary. And in this case, too, we have the Rotarians within the country, particularly in Africa, who are willing to personally get involved and open doors with the ministries of health and others. At the same time, the fundraising activities with the Rotarians in the US, Canada, and other places to really help the whatever needs in COVID-19, we are ready to support and partner with all of you. At the same time, we have helped a lot of the companies that bought airplanes from Boeing. Just recently, Ethiopian Airlines picked up a new airplane, and we collected a lot of PPEs, and the airline gave us a free spot, and we delivered those to the Ethiopian government. So we're really looking forward to work with you in this endeavor, and reach out to Rotary, and we're ready to go. Thank you.
Great. Thank you, Ezra. I do see a few more hands, and Cyril, I'm going to give you the floor in just a minute, because I actually want to put a question to you, so maybe I can call on you just shortly. But Carla, if you have a very brief comment, do you want to make that, or do you want to wait until our breakout sessions to where we're more focused on solutions? Is it a 60-second comment, Carla?
I can wait. That's okay. Actually, I'll make a 60-second comment. So just 2 quick comments, and that's that the thing to keep in mind, in addition to Trina's point, is one that not just are we talking about how vaccines will be targeted globally, but also within the countries. There's been a lot of diversion of supplies and of the workers, like the PPEs, from the community healthcare workers and to the community that were already earmarked for that. So that last mile aspect is really going to be a huge challenge to overcome. And I'll do the second one in a different.
Great, thanks, Carla. So we want to move now and kind of shift our thinking a little bit from, really good discussion on the problem statement and kind of the context. I'm just sort of looking through some of my quick notes. I mean, I think thinking about the intended recipients of a vaccine, some of the very real challenges around supply chain and the requirements there, especially around ultra cold chain requirements. My words, not yours, but combating and really reducing the hesitancy for a potential COVID vaccine and making sure that people are getting good information from trusted sources, that there actually are better data, better testing tools and things, so that we have a better sense of the scope that we're actually up against, and then the financial resources that are required across all of this. So a lot of really important areas. As we prepare to go into two smaller breakout groups, I want to just kind of tee this up by saying, first of all, we want people to hopefully bring really specific ideas for interventions, for opportunities that have kind of a disproportionate or exponential impact given the resources required for those potential solutions. We've also been asked to take a shorter term, so kind of a 12-month, 1 year point of view. So interventions that could be made realistically in the very near future that could have an impact. They might be things your organization is already doing. They might be ideas you've had, but might need to be taken up by others. Certainly principles around equity, around decolonization, around building that local capacity are really, really important. And then we'll come back all together in a little bit. To kick this off, though, I do want to go to Cyril and Samuel really quickly. Cyril, in addition to whatever you want to share based on the previous conversation, I'd love to get some of your perspective on just on this equity question and what we can be doing as NGOs or as companies to be thinking about how global health can be made to be more equitable, and how that broader equity actually lends itself to greater efficacy in the long term. So I'll go to you, Cyril, for 2 or 3 minutes.
Great. Hey, thank you very much, George.
Can you hear me okay?
Yeah, Samuel, let's go to Cyril first, and then I'll come back to you, okay?
Okay.
Go ahead, Cyril. Thank you. So Cyril Engman, PATH and the University of Washington. I think my first comment is, let me make a disclosure. Any conversation about COVID is intensely personal to me. I've lost colleagues. I put myself in the line, and we're looking forward or not looking forward to the next, to this period where we're seeing more and more cases in ICUs. And so this is intensely personal to me. The other reason this is intensely personal is I'm privileged to sit on the NIH expert group that looks at all the trials that are going on in COVID. So despite the noise and the chatter, we've sort of focused on the science and are deeply involved in all the different elements of the trials and providing expert inputs. That's very personal. And then the last part of it is one of the roles I have is at PATH, where we're right across the organization, whether in drugs or devices or vaccines or public health systems, we're deeply involved in thinking about COVID. So that's my disclaimer. But to the point and the framing that we have, which is what do we need to do to get better vaccines to low and middle income countries? I'm a little bit, I think we may want to modulate that a little bit, because as Trina rightly mentions, there's such an emphasis on vaccines, and particularly with someone who has a view on vaccines that will continue to evolve. I mean, we don't have a vaccine that, has had 6 years of phase 3 trials that everyone can point to its efficacy. We have vaccines that are very early in their evolution. And so making major plans primarily in that direction as the main lever against corona or COVID is probably not the entire framing that we need to do. And so to Trina's point about emphasizing some of the non-vaccine preventive aspects, I think, are hugely important. And then there's a dimension of actually how to manage cases of COVID that happen, that again are part of the conversation, an important part of the conversation. In the same way that we'd have a saying, when we're thinking about influenza, we need to still recognize that there's still thousands of people who die every year around the world. And then to something that we've begun to nibble at a little bit, which I think is part of the crux of the matter, is actually the unintended consequences. And I know we all are very much aware of this, that, you know, you have an epidemic and it causes X condition, but actually affects 20 times X in other types of conditions. And part of that argument may be well established amongst ourselves. I'm not convinced that they're fully established in the minds of, for example, a minister of health in a country. And so my first sort of, as we are trying to lay out the framing of this conversation, is let's not assume that the folks who are on this call who represent the Seattle global health community are going to come in from a sort of north to south approach. Let's actually think about whether the data is actually equitably available, so that ministers of finance or prime ministers or presidents and so on will actually have some degree of helpful information that they can contextualize to make decisions. They may have smaller resources, but as Ami pointed out, you can have many more resources and still have bungle an issue, right? And we've seen that very well demonstrated here in the US. So to me, part of, I think, the framing is, how do we highlight the economic argument even more? And what sort of data do we lend into that? So that's the first sort of comment that I was going to make about the framing of the issue. And then if I can just make another comment to the second question, which is, how do we think about equity? I have to be honest, and again, this is something I was super excited about, but it seemed to sort of drip with the very problems that we're trying to solve, right? A lot of people in Seattle, in the locus of power, trying to figure out how to sort things out in low-income countries. And frankly, you know, this is exactly part of what we're trying to avoid, this sort of, or trying to address as we look in the mirror a little bit harder at ourselves and say, what are we trying to do? How are we trying to decolonize global health? It sort of, I was struck when I saw the first list of those who were attending, to sort of recognize that everybody actually, well, the first list I saw was from a high income setting. And then, you know, of that, how many people of a healthy complexion, talking of where was diversity and equity and inclusion that would actually bring out even more of the creativity? You know, fortunately, we're beginning to pad that out a little bit, but I think that until we get to the point where we're beginning to really be thoughtful about where power sits and some of the sort of the irony of sitting in Seattle at this time, having conversations about what might happen in low-income countries when very few people are being represented, and the time difference anyway would be rather late. I think those go without saying. And so in terms of practical things that we could do, not just about the equity issue, but about all the COVID issue as well, I think, again, I come back to data. I think being very intentional about gathering the data so that fully capable folk can be much more dispassionately challenged, and making and using that data to drive the economic argument, I think, are going to be some of our best bets. Over. Thank you.
Thank you, Cyril. And I think the critique, the observation is really well stated, and I'm seeing some comments in agreement in the chat as well. You know, it is, for better or for worse, it's, you know, global Washington has brought people in this part of the world together to have some of the conversation, but absolutely agree that putting, ensuring that local governments and practitioners are in these kinds of conversations is so important. I think it's one of the reasons that it's so great to have someone like you from PATH here. PATH obviously being headquartered in Seattle, but increasingly really drawing on the strengths of its global offices to be making some of those decisions and driving programmatic work. So thank you for that. Samuel, I want to go to you before we go to the breakouts, and perhaps in the same vein, as as the country director for the Hunger Project in Ghana, are you able or willing to share some examples of what you see in terms of what's working to strengthen health systems there? And are there examples or good principles or traits of what scale can look like that you'd be willing to share with this group before we go into our breakouts?
Thank you very much, George. Yeah, the Hunger Project has been working very seriously, side by side with the government in trying to, lower the effects of the COVID pandemic. In every public health campaigns, trust is absolutely crucial because people must trust that they are receiving the correct and unbiased information. And that is exactly what the Hunger Project tries to leverage on with the public sector, what the public is also providing. Because the Hunger Project has been working with what we call animators in communities. In fact, we work among 350,000 persons from 450 communities in Ghana. And we work through 3,000 animators who are community volunteers and leaders. These people are known by the people and they are trusted by their neighbors because they are known by the people. And it is very important because since they are very much known by the people, they believe whatever they tell them. And in fact, as we are going into the next phase of COVID response, that it will require immense buy-in from the public. We all know that we are now moving to the phase where we are introducing vaccine campaigns around the world. And I will say that institutions that will be managing these campaigns and then backing them with funding should ensure that community mobilization is built into the implementation plan. Because it is only through this that people will trust whatever is being done. The use of community animators in mobilizing people exudes trust, ownership, and inclusion, and proves to be a quick, effective, and sustainable way of mobilizing people's power and bringing everyone on board. We have tried it in Ghana and it has worked. And so by including this community and making them to participate through these animators, we are sure to reach large numbers of persons, and then people will own whatever they do. So this is what the Hunger Project is doing, and we trust that if this approach is built into it, then we will have a far-reaching results, especially with the vaccine campaign that we are set to roll out. Thank you very much.
Thank you, Samuel. I think really, really great points around that ownership, the inclusion, the community involvement. Those are all going to be pieces that are so elemental to building that trust that ultimately will make any intervention successful. Okay, we're going to go into some breakout groups. As I shared earlier, I'm hoping these will focus on potential intervention solutions, things that can happen in the next 12 months or so that can really have impact. They might be simple, they might be complex. I would encourage you not to over-engineer things, but where you have ideas of or have seen examples of programs that are highly effective but not difficult to deploy, that's maybe the sweet spot. I'm going to let Pratima and/or Kristen's team guide us. We're going to go into two groups. I'll be with one, Kristen will be with the other to sort of help moderate. Each group should think about a rapporteur to when we come back, share some of the highlights very briefly in about 3 to 4 minutes. of what your group talked about. And we will come back into this plenary room at 20 minutes to the hour. So we've got 35 minutes for this discussion. Pratima, any instructions for us, or will we just, and these groups might be a little different. This was a previous list. So Pratima will put us in our breakout rooms, and Zoom should show you a little notice saying you're moving to breakout room 1 or breakout room 2. And you may or may not have to click a button to accept, but Pratima, anything else there, or do you want to just take us away into our breakout rooms?
Yeah, thank you, George. I'm just going to open the rooms now, and you should all be assigned to your rooms. Thank you.
Great. And then we'll be automatically brought together again in 34 minutes.
And thought about some fundamental themes and aspects to think about this in the next 12 months. And a couple of the thoughts are really thinking about, first, as we sit in Seattle, as organizations based in Seattle, there's a few fundamental things to think about. One is people, programs, and the ways of doing business. So again, that's something internally that we can all think about within our organization or company. And it's also the fact when you think about people is who's at the table, or if you have to pull a chair away or create another chair for somebody else to come to the table that's not always there. Again, if thinking about our programs, what I know of Global Washington members, they already have a fundamental principle of having strong partners within the countries where they work, and hiring people from those countries and pushing decision-making in countries. So that's fundamental aspect, but we can all do that more. And we need to do that more in this time period. And almost, and to the fact Cyril came up of really even pushing your funders in that direction, and have principles that if your funders won't agree to, you can even walk away from those funders. So really hold true to your principles. And again, in the way we all do our businesses and implement programs. Along those lines too, there was a strong emphasis that the best solutions during this time and best solutions to COVID will be found in low and middle income countries, not in the US. I don't think we've proven that we can do this in a good way. So we should put that first. We can take lessons learned from the United States and maybe lessons where we failed, but we really need to find those solutions at the local level. And again, emphasizing that not all countries will have the same solutions. You need to take this a country by country, even a community by community approach, and lift up those solutions that are country-based and come from those communities. Africa has shown us in many ways that they're better prepared because of the past with Ebola, and also because they cannot afford when their systems don't work. That's not an option. So these systems are more resilient than you think. We in the US could serve for that, to be champions of what they do. We can broadcast out the good solutions, the examples that we've heard from Village Reach and World Vision and Path, that our role is to really broadcast good solutions out there. And the one I love too is that we're a group, a roundtable in Seattle, right? We need 100 of these or more going on throughout the world even. And that, and I can put this on Brookings, that we can use this toolkit and this model around 17 rooms to really push out more conversations, and then provide bridging and linkages within that. And that includes pulling into donors. Another aspect that just came up, because not everyone's working really on COVID and vaccine delivery, but all of us are working on health systems, and also protecting the mental health of our staff and of the people around during this time frame is really critical. Also doing kind of an agile process where you're really looking to enable people with good information to make decisions, including policymakers at the local level, and the cross-cutting collaborations that are needed. And just a reminder that we're all in this for the long haul, that we need to really focus on the PPE first and the distribution and what that means for everyone, but then also don't let up in the longer course of this pandemic. I think I'll stop there. I'm sure there are other things that I could put into categories when I have a bit of time.
Yeah, thanks, Kristen. Some similar themes, I think, certainly around, making sure that local governments and countries really are at the center. And as I think it was Emily who used this term a few times, we need to really think about increasing the signal and decreasing the noise, so that they have the right information and can do with it what they need to do. A similar mention on our side around PPE, and that actually remains really critical, although it seems that perhaps donors have lost some interest there. A few other things, we talked a little bit about just the importance of cross-sectoral approaches, that COVID is not happening in isolation, and there are still very real health challenges and health needs that are ongoing, and that actually may be an opportunity, that there might be opportunities to piggyback on top of COVID vaccination delivery, other important health needs that are especially important at the country or the local level, which would actually lend itself to a more locally sustainable and robust COVAX or COVID vaccination program. Talked about learning lessons from other immunization programs, the generational rings approach around smallpox, HPV, and some of the successes there. We spent a lot of time focused on the critical importance of healthcare workers, and how they really need to be leveraged, how they need access to good, reliable information, that a very tactical suggestion was made that to the extent we can support countries in putting together a definitive list of those healthcare workers that actually need or will be the priority recipients of a vaccine. That's very tangible, very tactical, can happen, you know, in a pretty low-tech way, but could have outsized impact. And then making sure that countries have platforms that they can use to actually communicate and get good information to those healthcare workers. Lots of other ideas, really good, robust discussion. I've taken some notes too. But Kristen, I know time is short and we want to let people go at the hour. You want to just, I'll turn it back to you to share any kind of closing thoughts and kind of thoughts on next steps. And I, for my part, will just say a big thank you to everyone for participating today. Some really robust discussion. Certainly 2 hours, while great, is not enough to do it justice. But we hope that this has spurred some thoughts and some dialogue that will continue. So Kristen, to you.
Yeah, thank you so much. Thank you, George, for facilitating. We do want to end on time. So again, thank you, because I know your time is valuable in the work that you do. So I truly appreciate the 2 hours you spent with us. And again, this is just the beginning of an ongoing conversation. The material from this will be created, we'll create a report that'll come out in late December, early January around all of the 17 rooms that we're doing to look for some of those fundamental aspects that we all need to have in order to get the SDGs back on track. This conversation in particular, it was fantastic to think about the global health implications and also the equity and the whole idea of decolonizing global health and development. So I truly appreciate this conversation as it feeds into future ones. I hope that you all stay engaged. There's a link to our national forum in the chat there. And we will be having breakout sessions around different topics and also plenary sessions for you all to view. And as I mentioned, we hope to convene this group again, and we're looking for your suggestions on how to expand it, to change it, different conversations. We hope that you met someone here that maybe you didn't know, to keep in touch, think about future ways to work together. But we hope this inspired you, and we hope there's something here that can help in your thinking as we go through this pandemic and this actual very difficult time in the next 12 months. So with that, I'll let you all go. Thanks again, and we'll send you a recap and follow up after this. So thanks very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.